This is what we would do a long time ago before we had artificial valves. We would just, in a patient who wasn't a candidate for surgery, just do a balloon valvuloplasty to help them. Unfortunately, it doesn't last very long, maybe a month or two, and the aortic stenosis comes back.
I'm going to make your heart beat very fast right now.
Now, one of the things that they're doing is they don't want the balloon to move or the TAVR to move when they position it, so they're going to make the heart beat very fast. This allows the heart not to pump blood out, and so the balloon will stay in position. It's only done for a very short period of time. So now they're pacing her heart very fast, and so her heart is not ejecting right now. So no blood is going anywhere. And now dilate the valve, and now let her own heart come back and let her heart eject. So that's how short it was, a very short period of time. But during that time, there's no blood being ejected from the heart, so that balloon does not move. It stays exactly where it is, and that's very important.
Keep it straight, please. Good. Keep it, push the wire in a little bit. Good. Almost out. And I'm out. It's okay. I got it. Okay, balloon out, please. All right.
Okay, so now we're getting ready to position the valve. And the nurse is bringing the valve up to the table. Again, it's been crimped and loaded on the catheter. And you'll see once, it doesn't take very long now that everything has been prepared.
Hold the wire, please. I'm just connecting the RFA here, guys. Okay, ready there? Go there, push the ground. Pay attention to the wire, Arthur. Go there. You guys ready? All right.
Now these catheters are positioned over wires, and the wire, again, is in the heart itself through the valve. And the TAVR valve is going to be passed over this guide wire and then positioned. And again, this is done under direct vision using fluoroscopy, which is the X-ray technology, which allows us to see exactly what's happening.
Okay.
Even though, again, there's not an incision on the patient's chest.
Remove the big IV we have in. And you're going to feel pressure. And we're going to
and the amazing thing, you probably can hear it, but Dr. Adesanya is having a conversation with the patient as this is going on so that they're aware of what they're going to feel and what they're going to sense, and so there are no surprises for them. It's absolutely amazing.
16 cranks out. All right. Clean the wire to the tail.
And you can see it's almost like a symphony. Everybody has their moves. They've all known their moves. They've done this many times, but it's really wonderful teamwork. Everybody knows their part and what they need to do to make this a success.
Okay, you're gonna feel that pressure in your groin now, darling. Okay, I'm gonna insert the valve now. All right. Who has the wire?
And so the valve is now being introduced into the artery in the groin called the femoral artery. And Dr. Adesanya has just put the crimped valve that's on the catheter into the patient. And you can see on the fluoroscopy, the valve has now entered the patient's chest, but it's not in quite position yet. And he's now going to spend the next few minutes putting the valve in the correct position. You're going to see it slide around. It's in a large blood vessel called the aorta, which comes up the patient's back and then takes a curve, and we call that the aortic arch. And you're going to see the valve curve around the arch and then come down into the ascending aorta. Here it is. It's going around the arch. It's going around the curve, and it's coming down into the ascending aorta. And the beginning of the ascending aorta is where the heart meets the aorta, is where the aortic valve is. And so that's where he's going to position the artificial TAVR valve. And again, it's all done by visualizing it with X-rays.